We know that the bispecific antibodies targeting CD3 and CD20 are approved for treating relapsed or refractory large cell lymphoma. The two agents are epcoritamab and glofitamab. The dosing of these agents typically involve weekly ramp up to reach the target dose. Basically, there are 2 weeks time where you go from the first to the second dose and then finally reaching the target dose. The challenge in patients with the relapsed refractory large cell lymphoma is that sometimes the disease can be very aggressive when they are at that stage. So there is a desire to ramp up these bispecific antibodies faster to reach the target dose faster. So that's why we did this study, and it's a retrospective multi-center study looking at the feasibility of such a rapid ramp-up schedule of dosing in these bispecific antibodies. So we had a few centers from the United States, total 38 patients included in this study. So as we can imagine, most of these patients had unfavorable disease characteristics. For example, 3/4 had primary refractory or early relapse after their first-line therapy. And the patients had a median of 3 lines of therapy previously before the bispecific antibody. And 2/3 had a prior CAR T, and 60% were primary refractory to the last line of therapy. And at the time of bispecific dosing, these patients tend to be sick and frail, and most patients had elevated LDH and bulky disease, and over 1/3 of patients had ECOG PS of 2 or above. So again, in these patients, we attempted a rapid ramp up, a total of 38 patients. One patient had what we call a regular ramp up between the first and second dose, and then a fast ramp up within just 2 days to the target dose. But for the rest of the 37 patients, they all underwent a fast ramp up from first dose to second dose between anywhere 2 to 4 days. And then most of the patients went on to receive a fast ramp up to the third dose as well. A few patients kind of slowed down to 5 to 7 days for the second ramp up. But overall, 80% of the patients were able to reach the target dose within a week, and another 15% of the patients were able to reach the target dose within just 8 to 11 days, still faster than the regular dosing. So in terms of feasibility, first of all, we demonstrated it can be done, and in terms of safety, the CRS rate throughout the entire ramp-up period is about 40% of occurrence, and mostly grade 1 to 2, only one grade 3 event, and that's short-lived. In terms of neurotoxicity, or we call ICANS, a little bit tricky. 2 patients had a grade 1 to 2 ICANS, and 3 grade 3 were reported, although I have to note that at least 2 of those 3 events that were reported as grade 3 ICANS had an alternative explanation of the clinical presentation. One patient had a seizure, which was interpreted as a grade 3 ICANS, but on imaging he had a lymphoma progression in the brain, unfortunately. And another patient, although again reported as grade 3 ICANS, but it was in the setting of septic shock and altered mental status, probably not a true grade 3 ICANS event. But overall, in terms of ICANS and the CRS rate, is pretty similar to those reported in trials and a large real-world series. In terms of response rate, very close to the trial data, 50%, although the CR rate is only 20% in this high-risk sick patients. And in terms of duration response, 4 months, and a median overall survival 6 months with this short follow-up. So not to interpret too much from the efficacy data, but in terms of feasibility, we can get it done to reach the higher dose within a shorter time duration and with similar safety profile to the larger real-world series. We think these small cohort patients really demonstrate the proof of concept and the feasibility of rapid ramp-up.